Good morning, good afternoon, good evening, as the place you are in. Welcome to IOMP School webinar. Today's webinar is Global Perspective for Advancement in Radiation Oncology. And this is jointly organized by Simone, Ibrahim, and myself. And in this IOMP School webinar, there will be 3 speakers. All the 3 speakers will have their presentation. During the presentation, the delegate participant can put their questions, queries in Q&A, question and answer, and not into the chat box because they will be lost there. And in question and answer, only put your queries and questions, because I am seeing somebody again there also putting good morning, good afternoon. That is not the way to do it. And this first speaker is Dr. Dayanand Sharma. He is a very well-known figure and he will be talking about the adaptive proton therapy. He is a professor and head in Department of Medical Physics, Apollo Proton Cancer Center, first proton cancer center of India, and he has more than 28 years of the professional experience and the first medical physicist to clinically commission the first proton therapy facility in Southeast Asia, and he has more than 56 publication abstracts. I will not go into much more detail because they are available on the website of this program also, because we need to give time to the speaker to speak. Second speaker is Dr. Helio A. Salmon Jr. from Brazil. And he will be talking about Brazilian experience, steps to organizing a proton therapy project, and what we are talking about democratization of the proton therapy because of very expensive, very costly affair, how it can be organized a project. He is a chief medical physicist and executive director in Brazil, and he has a very, very long experience and more than 110 bunker projects and CNE licenses he has worked for. Very long experience he has got. Another third, the speaker, very eminent speaker, Rabih Hammoud, who is from he is talking on AI in medicine, opening the black box for patient-centered treatment and things. And he has also very, very vast experience about this thing, and he is very active into the MEPOM region. With this brief introduction and request to all the speakers to stick to their time of 15 minutes, all the delegates to kindly put your question and answer into Q&A, and all the questions will be taken at the end of the 3 talks. Welcoming all the 3 speakers, Ibrahim, Duhaini, Simone, and thanks again Magdalena, who is behind the curtain working very hard. I hand over the floor to Dr. Dayanand Sharma to start his first talk. The floor is yours, Dr. Dayanand Sharma.
Thank you, Professor Chougule. It is greetings to everyone from around. Let me just adjust slides. Okay.
It's visible. Go ahead.
Yeah. Okay. Greetings to everyone. So it's truly an honor and a pleasure to be part of the IOMP school webinar. I am Dayanand, and today I'll be speaking on adaptive proton therapy. So in this talk, I'll start with the rationale of proton beam therapy. Then we'll try to understand the clinical implications of adaptive proton therapy. Then I'll navigate the current status and the challenges of online adaptive proton therapy. And finally, I'll just highlight the future directions of adaptive proton therapy. And at the end of the talk, I think we will be able to understand the evolution and the promises of adaptive proton therapy. So before we dive into the adaptive part, let me just briefly explain why proton therapy is important. And of course, the rationale lies on its unique integrated depth dose characteristic, which is also known as the break peak, as shown over here, and which is characterized by a lower entrance dose followed by a maximum dose at the specified depth, which is also known as the range, and the no exit dose beyond the range. So in a clinical situation, so what we do is we use our multiple Preston break peak, and we superimpose all of them to spread out the break peak so that it can encompass the target volume along the part of the beam. And this gives an advantage of protecting the critical organ just at the distal end of the spread out break peak. And this allows us to spare more critical organ. So in a clinical situations like sacral chordoma, which is a radio-resistant tumor, because of its able characteristic to spare more critical organ because of the lack of the exit dose, you can escalate the dose to the tumor, which will provide or which will improve the survival, at the same time reduce the toxicity, and at the same time reduce the risk of secondary malignancy. So but the proton beam therapy is highly sensitive to both inter and intrafractional uncertainties, which can be due to the patient setup, the respiratory motion, anatomical changes, and most importantly, the proton beam range, which is different than that of photon. So in this example, when we introduce a high density medium along the path of the beam, then in case of proton, it simply perturbs the dose distributions with a minimal dose. But in case of proton on the carbon ion, I think any kind of charged particle, the range is completely shifted, and which leads to the complete underdose of the target and the overdose of the critical organ. So, so in these clinical examples, wherein there is a dosimetric study was conducted on pancreatic patients, and the BMET technique using X-ray beam have shown robust treatment plan, even though there is a large change in the GI gas volume during the entire course of treatment. But in case of proton and the carbon ion therapy, which shows reduced target coverage of the order of around 8 to 10% because of the sensitivity of the proton range in various anatomical changes. So several strategies were used and in clinical practice to make proton therapy more robust. The first one was the implementation of robust planning techniques, wherein both setup error and the range uncertainties are incorporated into the optimization process to create a treatment plan which maintain the target coverage despite having the proton range variation. So most centers nowadays use CTB-based robust optimizations, which has shown more effective than the traditional PTB-based IMPT planning, like in this case of head and neck cancers, which has been reported from the MD Anderson Cancer Institute. So other studies, including those from the University of Maryland, highlight that the use of multiple fill with beam angles having less sensitive to tissue density variation also improves the treatment plan robustness. So adaptation of sequential and the conventional fractionation schedules also have shown to enhance the plan robustness. And but despite of having all these strategies, there are still some variations which cannot be taken into account. So the advanced technique like anatomical robust optimization have been proposed from the PSI in Switzerland, and they have demonstrated that the use of multiple synthetic CT scan during the time of optimizations with the possible variation in the anatomy can improve the plan robustness. But this technique is very intensive in terms of computations, right? So in our centers, we have adopted we have adopted a robust anatomical robust optimization technique using 3 CT scans. One is the planning CT and another one are 2 synthetic CT scans with one assuming this sinus as completely empty and another one as completely filled. And but this works really well in this particular case, but it doesn't guarantee that the same technique will work well for other clinical site. So we need to evaluate it on case-to-case basis. Although I think the use of only 3 synthetic CT proved to be more efficient in terms of planning, but it may not work in all clinical sites. So we need to have a case-to-case evaluation. So considering that, I think if you see, if we consider this clinical example, all strategies remains inadequate for significant interfractional anatomical changes, which can be as high as 25% to 30% reduction in the CTV volume due to the weight loss in this case. Okay, so this is a study from MGAs, and so this kind of significant anatomical changes cannot be adequately handled with strategies which we have discussed just now. So this is going to lead to lots of dosimetric variation. Say, for example, this is the original plan, and in N fraction, there is a significant weight loss, and as a result of that, there is a underdose of the CTV and the overdose of the skin dose. Another example, the breast swelling during the treatment led to increased skin dose and underdose of CTV. Another example, change in nasal cavity filling status led to underdose of CTV and the increase in dose to the brainstem. And even the poor setup reproducibility led to underdose of CTV and the increase in skin dose as shown in this example. So we need to adapt, or we need to adapt the proton therapy, which will allow us to adjust the dose delivery in response to the patient's changing anatomy. And so currently we have 2 adaptive strategies. One is the offline adaptations and the second one is the online adaptations. And to understand the practice-based pattern across the world of adaptive proton therapy, a global survey was conducted covering 70 proton therapy centers across 17 countries. And the result shows that 84% of the centers use adaptive proton therapy for at least one clinical site. And the majority of the centers use the adaptive offline adaptive proton therapy on ad hoc basis, whereas around 33% of them follow some sort of protocol. So most common site which needed adaptive proton therapy are head and neck, followed by lung and the prostate. And a similar observation was met in our centers, where more than 68% of the centers had planned to implement or improve their adaptive workflow in the near future. And among all those, I think the offline adaptive proton therapy is the most commonly performed adaptive technique compared to offline. So this is currently at our centers, we use offline adaptive, and this is a simplified workflow. So we rigidly register original planning CT to QA CT, which can be taken either as part of protocol or trigger based on the CBCT variation, and then the dose is computed on the planning on the QA CT. If the variation is well within the acceptable limit, then we proceed with the original treatment plan. But if the variation is beyond the acceptable limit, then we go for the complete replanning. So, but in the new studies suggest that there is an emerging trend of comparing the online versus offline. So which one is better? So online seems to be more promising. Is it maintain better target coverage even with small margin? And it also helps in reducing the cumulative target dose in this study from MGAs are around 5.2% for offline as compared to 1.3% for online. So moreover, it reduces the OIR doses. But the worldwide survey also shows that the main barrier for implementing and the implementations and the improvement of adaptive workflow was the lack of integration and the efficient workflow. So the consensus guideline from this survey concluded that the key urgent needs for clinical implementation of online adaptive proton therapy are the higher quality of in-room volumetric imaging, then reliable dose deformation and the calculation, and finally automation and the speed for dose accumulation. So, but if you see the CBCT image quality available from the proton therapy systems, I think they are really poor. So they are the limiting factor. And so because that is because of the presence of the artifact, and that's also the incomplete anatomy due to the limited FOV. So this makes it inadequate for accurate proton dose calculations until and unless you do some sort of correction. So different techniques have been proposed to lookup table, using lookup table based correction, histogram matching, deformable image registration, projection-based correction, and the most recently deep convolution neural network-based corrections have been proposed to generate the to generate the synthetic CT from CBCT. These methods have the potential to enhance the image quality and the Hounsfield unit accuracy, making them more or less comparable to planning CT. So in a recent publication from the University Medical Center Groningen, they have compared three synthetic CT generation method using the convolution neural network, deformable image registration, and analytical correction. And they have evaluated it against the same day repeat CT scan. And what they found is that the deep neural network achieved the best performance with lowest mean absolute error of Hounsfield unit, highest dissimilarity coefficients, while both convolution neural network and deformable image registration produce accurate dose calculation. So analytical correction methods, however, showed lower image quality and reduced dosimetric accuracy. So those some of these algorithms, though they work in some clinical site, they may not work well in clinical situations where in large anatomical deformations are present, like in case of pelvic tumor. So in these collaborative studies, we have developed a hybrid methods using a boundary conditions on controlling regions of interest to generate a synthetic CT from CBCT, which is not only accurate for proton dose calculation, but also preserving the geometry of the OR. To improve efficiency and reduce inter-observer variability, several in-house and the commercial auto-segmentation methods based on various framework have been developed and adopted. And we evaluated the deep learning auto-segmentation model of ray station in 125 patients of head and neck cancer, representing a near real-world data sets. The method was accurate for 31 ORs, requiring minimal expert intervention, and it took an average of less than 10 minutes for auto-segmentations and expert corrections. So the dosimetric difference due to the variation in the ground truth and the deep learning auto-segmented ORs were less than 300 centigrade in the mean dose for those patients who treated with the intensity modulated proton therapy. So last year, PSI Switzerland, through their publications in PMB, claimed the first clinical implementation of Delhi online adaptive proton therapy. The workflow is classified into three phases. In pre-treatment phase, the optimized treatment plans and the fallback plan was created on planning CT. On online phase, they optimized the adaptive plan on Delhi in-room CT images. So rigid propagation of Delhi structure from planning CT was performed, and they adopted a automated QA process, and at the same time they also have evaluated the clinical goal using a traffic light protocol. And whenever they are not able to fill the clinical goal, they use the fallback plan to treat the patient on that day. And the results are quite impressive. I think the average online adaptation, including the QA, was less than 7 minutes per fraction. And the average session time was around 23 minutes, which is well within their set 30 minutes slots. And Adapted plan delivery, the adapted plan was delivered in more than 85% of the fraction, and the 92% of the fraction shows improved those metrics to target and the OR using this online adaptive approach, daily online adaptive approach. So the online, MGAs is also another centers who are actively engaged with the online adaptive proton therapy protocol. And they have compared, in this study, they have compared the different approaches adopted at MGAs and the PSI. By comparing the MGA's partial beamlet dose computations with the PSI online planning and the full re-optimization, in this study, they have included 10 patients of head and neck cancer, and the synthetic CT scans were created by deforming the planning CT to daily cone-beam CT, and the target and the OR were also deformed on daily images. And so the tree optimization approach was the 20% beamlet optimization, which is followed at MGAs, full planes optimization, which is followed at PSI, and the full online replanning, which includes both fluence and the beamlet position modification. And the results are, again, I think, quite similar. So outcome of the study shows that all adaptive workflow meet the daily target dose prescription, although full dose optimization shows only 0.4% deviation in CTV coverage at the cost of longer longer time, which is around 72 minutes compared to around 2.2 to 2.4 minutes. So in conclusion, a significant number of patients benefit from adaptive proton therapy. Head and neck case leads the NIT and followed by thorax and the pelvis. Currently, offline adaptive planning is the most widely practiced approach. Systematically designed mitigation strategies can reduce the frequency of replanning. Synthetic CT scan from CBCT showed strong potential for accurate dose computation using intensity modulated proton therapy. Online adaptive planning is highly promising, though challenges remain. So integration of machine learning based auto contouring, automated planning on synthetic CT scan, and automatic patient specific QA could make the online adaptive planning a clinical reality, and it shows a great promise in the upcoming days. So with this, I thank you all for your kind attention, and this is the team at Apollo Proton Cancer Centers who have contributed in my presentation. Thank you all.
Thank you, Dayanand Sharma, for an excellent talk on the adaptive proton therapy and what is going on in the world and how we can adapt those things. What are the limitations and things you have very nicely explained. And I said that you have a long experience of working in proton therapy. The largest proton therapy center in India. You are heading the medical physics large group, and your experience has helped many of us. There will be some questions and queries. Definitely, the participant will put it, and I will, at the end of that thing, I will put it. Now, I invite Helios Salmon. He is from Brazil. And now, how the countries like the countries with low or middle income countries, how they can afford, how they can establish, and how they can facility make available in the country. With your great experience of having established many radiotherapy center, it will be handy to us to get know from you. So, Dr. Helios, the floor is yours now. Kindly share your PPT and do the presentation.
One moment. Sumiu aqui de novo. Hello. Good morning.
Go ahead.
I will take about the steps to organize a proton therapy project. My name is Helio Salmon, and I'm the director of the Department of Radiotherapy at the Faculty of Medicine Vassouras in Rio de Janeiro, Brazil. Today, I'm honored to share with you the Brazilian experience in organizing a proton therapy project, the steps we took, the challenges we faced, and the lessons we learned along the way. I hope this presentation can provide guidance for institutions looking to implement this cutting-edge technology. So, in this slide, we're gonna see the difference about photon versus proton therapy. When comparing photon-based radiotherapy with proton therapy, we see a fundamental difference in how energy is deposited in the body. While photons release energy both before and after the tumor, protons deliver their maximum dose inside the tumor with minimal exit dose. This precision allows for better tumor control and helps us spare healthy tissues, which is particularly beneficial in pediatric and re-irradiation cases. Here, I scope into benefit for patients. These characteristics translate into real clinical benefits. With proton therapy can improve local control of the disease, reduce side effects, and lower the risk of secondary cancers. For children, this is especially important due to their long life expectancy. It is also the treatment of choice in complex re-irradiation scenarios where protecting previously treated organ is critical. Next is slide. Let's take the example of pediatric medulloblastoma. The dosimetry comparison between 3D conformal photon therapy and proton therapy clearly shows the difference in dose distribution. With protons, we significantly reduce the radiation to surrounding organs such as the heart, lungs, and liver, something that can directly impact long-term quality of life. Looking into the side effect, as you can see, the benefits clearly shows it. Now, I'm going to talk a little bit about FUSV. Let me introduce you to our institution. FUSV, the Severino Sombra Educational Foundation, was founded in 1967. It is a philanthropic institution managing educational and healthcare facilities, including the University of Vassouras and multiple hospitals and schools across Rio de Janeiro state. We currently operate 2 radiotherapy centers, and they are expanding to a third. FUSV is one of the leading providers of oncology services for Brazilian public health system. So, why invest in proton therapy? It's a great question for us, and I think it's for all that have interested. So why should an institution consider a proton therapy project? First, it's a symbol of technological excellence. A center capable of operating such a facility demonstrates clinical and institutional strength. Second, there's the halo effect. Visibility gained from protons can boost all other oncology services. Third, this is not a saturated market. Few competitors can enter due to the right investment needed. And finally, launching such a project requires serious strategic commitment from the organization. Before starting a project, it's critical to evaluate the external and internal environments. This includes the regional demand for advanced technology, reimbursement policies, and regulatory requirements. You also need to assess your institution's capacity to invest, the strength of its partnerships, and whether you have or can develop a qualified multidisciplinary team. Once you've validated your strategic alignment, the first step is to form a strong multidisciplinary internal committee. This group should include oncologists, engineers, managers, and institutional leaders. From there, create a robust financial plan, considering not only CapEx, but especially OpEx. Organize a detailed roadmap and assign responsibilities to the right people. Then look externally. Establish partnerships with institutions already operating proton therapy. We did this with Quiron Salud. Engage with the regulatory bodies early. Begin discussions with leading technology providers, even in a non-binding way. And you always remember, this is a long journey. Partnership and support networks will make a huge difference. On the infrastructure side, careful. Choose the construction site and conduct details, studies, soil, power systems, and logistics. Select a reputable bunker design firm. Plan early for clinical operation. Training your staff must start 1 or maybe 2 years before your first patient. Also, secure referral partnerships, particularly for pediatric cases, and define your strategy for OIS and TPS system, which are very different from conventional radiotherapy. Some recommendations. Based on our experience, here are a few recommendations. Choose providers with solid reputation and a large installed base. We select IBA, but others, like Hitachi, are excellent as well. Avoid companies promising disruptive but unproven technologies. Participate actively in professional networks like PT-COG and make sure your radiotherapy and chemotherapy departments are ready for the increase in patient demand driven by the halo effect. Now, I'd like to briefly share our current project. FUSV is building a state-of-the-art oncology center in Rio de Janeiro state, covering 100,000 square foot. It will be the first center in Brazil with proton therapy, and our choice was for IBA, Proteus 1, with the future plans for expansion. It will also include PET-CT, MRI, CT-SIM, chemotherapy, and robotic surgery, all in one integrated academy and research-oriented environment. Nothing has been signed yet. We are in the final details of the agreement. I hope by the end of the year, we have already reached the negotiations. And now, In conclusion, for institutions that meet the right criteria, structure, strategy, partnership, and vision, the time to start a proton therapy project is now. The question is no longer if proton therapy will arrive in our countries, but when. Those who prepare early will lead this transformation. Thank you for your time and attention. If you have any question, please feel free. Thank you very much.
Thank you, Helio. Briefly describing the how you can implement the steps for implementing the proton therapy center and your Brazilian experience where you have taken the steps, and the technology is very good, but the finances, maintenance, the manpower, all aspect taken into this thing. So it will be a good lesson for many delegates who are thinking to having such an advanced technology, what preparation assessment needs to be done before venturing on such expensive project that you have very nicely elaborated. And it's a first project in Brazil. Thank you very much, Helios. Now you can unshare your the PPT. And now I am going to invite Ibrahim Duhaini so that he can introduce our Rabih Hammoud, the third speaker.
Thank you, Harun, for managing the talks. Very nicely done. I'm very happy actually to introduce the third speaker, Rabih Hammoud. He is a long colleague of mine since 1990. We came together in the journey of medical physics, starting from the college time. And it is an honor to have you, Rabih, in this talk. And I just also wanted to mention that Rabih and his team are planning to open the first proton therapy department in Qatar, in the Middle East. And but today he will be talking about the importance of AI in radiation therapy. I will give the floor to Rabih to talk about this controversial issue that we are facing in this era. And this is the importance of the International Day of Medical Physics, that I have my background, the poster that I would invite every one of you from now on to put this poster. And although it started to be a controversial because some of the images are originated by the AI, and some of them, they are like imaginary imaging, but they reveal the importance of the AI, the pros and the cons of AI in radiation therapy or diagnostic physicists. So Rabih will open the box today and will open our eyes to see if the AI is a good or bad to us. Rabih, the floor is yours.
Thank you, Ibrahim. Well, first, hello everyone, for all the participants that there are with us today. Ibrahim, I will call you brother. You are a brother. Ibrahim, Dr. Arun, Magdalena, IOMP, I would like to thank you for this opportunity to present today. I'm going to be talking about AI medicine in 15 minutes. I think I'm just going to be highlighting some of the developments that happen with AI. And as Ibrahim stated, the controversial issues that we're really facing, how much AI is an added value, yes or no, when and where. So I have to disclose that I don't have any conflict of interest, although we are Qatar, we are one of the reference center for variant in the region, and because I'm going to be using some of the variant systems here. So in brief, I'm going to be introducing AI to you guys. I will go a little bit deep into the AI in the health care in general, and then we'll talk about the health AI in radiation oncology, and then I will conclude with the challenges that we're facing currently with AI. Let me share with you where I'm coming from. I'm Lebanese originally, like Ibrahim, but now I'm leading the medical physics team in the state of Qatar in one and the only center within the states. Qatar is approximately 3 million. 90% of the population are expats coming from about 100 different nationalities. The proportion between male and female, it's 3/4 male and 1/4 female, and this is due to the fact that most of the population are workers and young, and that's what make an impact on the health system within the states. We have only one department of radiation oncology in the whole state of Qatar with very advanced technology. And as Ibrahim stated, we're working on a big center, comprehensive cancer center that will have a proton therapy as one of the modalities. Let's go into the topic. What is AI? In a simple statement, AI is devoted to make machines think and act like humans. This is not something new. We've done a lot of programming before, which is an AI, where rules and data were fed into the system, and then we're getting answers. So this is the classical program. You feed the system with rules and data, and then it will give you answers. If, then. In an AI world, you feed the system with data and answers, and the artificial intelligence system will predict rules for you. So the big umbrella of AI is any machine can do tasks like thinking, learning, solving problems, or even mimicking humans. So it's like a robot that plays chess or voice assisted systems like Siri. If we look deeper a little bit, we have machine learning. This is where we teach the machine to learn from the data and the experience without being programmed with exact rule, and let the system come up with a rule. So an example, an application that learns how to recognize spam emails by looking at thousands of emails. If we go a little deeper, we reach the deep learning. Deep learning is part of the big machine learning. However, it uses a brain-like structures called neural networks with many layers. So it's deep layers, and we'll learn from a lot of data. So let's look at the evolution of AI in health sector. Well, early AI systems, as I stated, they are rule-based expert system. One of the systems which is available in the 1970s is MySim. MySim is a pioneer rule-based expert system built to assist physicians in diagnosis. It looks at the infection, at the bacterial infection, and recommend antibiotics treatments. And this was developed by Stanford universities in the early 1970s. The rule base stayed within the 80s and the 90s, and then in the 2000s, we start seeing more shifting towards machine learning systems. So data were driven and AI emerges, and we start seeing application in medical imaging and diagnostic growth. In 2010s, we saw more development of deep learning. This is a big breakthrough, especially when it comes to imaging and genomics. In the 2020, with the COVID pandemic, we saw AI really integrates into the clinical practice. We saw a lot of solutions that coming AI-based, especially for COVID-19. We have now wearables, Apple Watch, for example, that can do clinical assessment for us and automations. Autonomous diagnostics is now available, which means that the AI system and the algorithm are able to predict the diagnosis and come up with the diagnosis without the intervention or without the support of a human being. And this is something very advanced in this. So let's look at some of the examples of AI in the healthcare. The first one is pathology and histology. Well, AI models help pathologists analyze histology slides faster and more accurately. They're able to detect cancerous changes that may be missed by the human eye, and this will lead to a reduction in the workload and will improve the diagnostic confidence. Many solutions are available in the market that will assist us with us. Lina, for example, this is an AI deep learning lymph node assistant, which is developed by Google Health to help detect metastatic breast cancer in lymph node biopsies. And this is a very robust system that's available now for pathology for breast cancer. Another discovery with AI is the drug discovery. So AI reduces drug development time from years to months. How this can be done? Because AI can predict the protein folding, looks at the drug interactions and the side effects before clinical trials. So in that way, we are automating the screening of millions of molecules. AlphaFold is an AI system that developed by DeepMind to predict the 3D structure of the protein directly from their amino acids. So it looks at how protein will interact with the molecules, understanding the mutations, and this will lead to drug discovery and expedite the process of drug discovery. Benvalent, this is an AI UK-based biotech company which uses AI and biomedical data to accelerate the drug discovery. So all these, they really help these AI tools to expedite the drug discovery by unfolding the protein structure. What about personalized medicine? Since this is a lot of data that we are dealing with, AI really supporting us in understanding more and more the patient data. So now we have a giant of data of genetics, lifestyle, and medical history. Now AI support will help us in looking at the history of the patients, maybe previous treatments, in order to assess the current status of the patient. So AI predicts how patient will respond to treatments. It will improve accuracy in cancer treatment, diabetes, and rare diseases. And this is where we're able to customize the treatment plan for each patient. Tempus is a US-based technology company where it uses AI and big data to help the physicians to make personalized treatment for their patients. Path AI, this is AI for pathology, where it's a Boston-based company that developed AI-powered pathology tools. So it will help the pathologist in order to make the right decision. It's assisting, and it can be autonomous too. So it can be without any pathologist support. What about AI in RT? Well, we know RT is a chain of processes that were involved from the diagnostic all the way to the follow-up. And AI is involved in every step of this processes, in the image analysis and detection, in the prioritization and triage, and in decision support. So there are multi-solutions. For example, Quantib Prostate, this is an AI tool that helps the radiologist with prostate MRI scans. This is another tool that's used also for breast screening, which is available also at the diagnostic, and these are AI-based. What about contouring? I think the previous talk, we saw some work that's done. Dr. Sharma presented synthetic CT, and this is all will be supported by AI. Artificial reductions is also available also to help us, and this is also based on AI. We know that now we will be able to do MRI only radiotherapy planning, and this is by the single, where we will be able to extract, for example, Dixon in phase images, synthetic bone versus synthetic soft tissue. Also, there is other tools which are based on deep learning, where we are able to reconstruct MRI diffusion weighted images. What about contouring? Also, Dr. Sharma shared with us some of the work that's done with that on the auto segmentation and the image registration and multi-tool special array stations. And he showed the validation of array station auto segmentations in their center. And there are other tools that are available from other software such as MIMS to expedite the process of image registration and auto segmentation. What about treatment planning? Plan automation is available, faster plan generation, such as Rapid Plan from Varian. We've worked on this, and this is a really robust system where we're able to really produce very quick plans based on the Rapid Plan. We've done it in multi-sites within the body, and it's very robust. I think this is an excellent tool. It will help new physician residents, for example, new treatment planners, new physicists, in order to produce a reasonable, standardized plans. Pinnacle also proposed auto planning, and this is also another tool which is available and based on AI. What about the quality assurance? AI for dosimetry checks and imaging, and AI in imaging QA. There are more than one solutions available in the market for that. This is the RotaCheck, which is an AI-powered independent QA solution where it will verify the RT plan using predictive dose model. This is another one. This is a deep learning approach, this is the work that it's published from Qatar, from our group, where we look at automated the quality assurance for the MRI based on deep learning approaches. And this is something that we published last year. What about treatment delivery? plan optimization for online adaptive planning. Dr. Sharma also shared some of the works done there, motion tracking and synthetic CT from CBCT. We have the ethos system in our clinic, and definitely AI will make a big difference in making online adaptive a reasonable solutions. So without AI, I think we're not able to have an online adaptive within reasonable time. And it is present at multi-steps within the adaptive online approach. What about the follow-up? I think AI will play a major role looking at response assessment, radiomics, toxicity prediction, and survival predictions. And I think AI will definitely assist us in the clinical decision-making, in the personalized therapy. It will improve the patient outcome, reduce the adverse events, and enhance the overall quality of care. However, I mean, these are all the benefits of AI. What are the challenges that we're facing with AI? Well, I stated the benefits, the diagnostic, the personalized treatment, the operational efficiency, and the patient care. But there are also mixed and the black box that within AI still that we need to answer. Who's regulating the AI? What about data privacy? What about the bias and the quality of the data? What about transparency? Shall we use just AI autonomy? Just will depend on it? I think it's very important to state that wherever you feed the system in, this is what you're going to get out. So garbage in, garbage out. So the quality of data is very important. There are more than one example that was really raised for example, in 2018, Amazon published that AI recruiting engine do not like women, for example. In 2019, another example where the healthcare used to identify patients who would benefit from extra care was biased against, for example, Black patients. So we need to assure that AI is fair for all. AI is still a black box for us, especially it has a multi-layer of neurons. Relationship between these neurons are complex and non-linear. So it's difficult to understand how the model arrived to its predictors or decisions. So, and then there is a lot of work currently happening, ongoing, to develop explainable deep learning models. It could be that AI learning to life, for example. AI models have been observed to generate sometimes misleading or fabricated responses. AI chatbots generating false medical information or faking scientific citation. This is happening. So will AI prioritize patients' best interest or its own efficiency-driven logic? Will AI-centered care, is there a risk for that? Is it going to prioritize due to cost cutting, looking at the hospital workflow, or maybe insurance policies over the patient needs? So we have to understand that. So I think we have some questions that we need to raise. Will AI impact clinical staff workflows, or is going to be an assistant for us? This is what we need to know. The ethical dilemma exists. Who is accountable when AI-driven decisions lead to harm? Who's going to be accountable for that? How to preserve innovation, creativity, and patient safety? And how will these devices and tools be regulated? I think we still need to understand how to operate AI tools for a safe and efficient RT treatments. And we need to look finally at QA tools to validate AI. Thank you.
Thank you, Dr. Rabih, for excellently giving the overview of AI. Any new technology, it has pros and cons, and that you have mentioned what are its limitations, what precaution one is to take. And especially in radiotherapy, your talk right from imaging to countering to planning to QA/QC, AI is being used, AI is helping, AI has improved the treatment delivery and the prognosis also, and also precision oncology or precision medicine, how AI is helpful. So thank you all the three speakers for excellently providing the overview of proton therapy, how proton therapy. Helio, can you just join, make it your the video on? And there are questions now, and I will put one by one question. It's a basic, but just I thought to make it because delegate has put, what makes the depth dose curve up of protons so different from electrons? Dayanand, you can take the question.
Oh, okay. So I think in this we are integrating the depth dose.
No, question is what makes the depth dose curve of protons so different from the electrons?
Basically, both of them interact in the same way, but the only difference is electron is a lighter particle compared to proton. So that's the only difference I could say.
Yeah. Anyone want to add, or just we go to the second question? What is the added effect upon the therapeutic dose of daily CT, CBCT for verification imaging in adaptive proton therapy on the increase of secondary cancer due to this additional dose of imaging may be a concern specifically for the pediatric patient?
So far, I think nobody has estimated the second cancer risks associated with the CBCT. But as you know, in radiation therapy, it is all about the optimization. So we have to optimize the risk versus benefit, and accordingly, we have to adopt based on the clinical requirement. But as far as the adaptive radiation therapy is concerned, it is a new technology, and it has just started mostly in the head and neck cancer, and only 2 centers is doing it for online. But of course, the offline, many centers are doing it. But if we just consider the CBCT dose as approximately 0.5 centigrade, I think it is not going to add too much or too much, because it is there even in the regular IGRT also. So only the thing is that we are increasing the frequency in order to closely monitor the dose deviation during the process of treatment. So one way we are improving the target coverage and reducing, in fact, in some situations, the critical organ, and that has to be optimized with the slight increase in the overall dose of the patient from the CBCT, which seems to be quite minimum to me, because if we consider 0.5 centigrade, even if we take 25 CBCT, it is for an adult patient, it is not going to be quite significant.
However, because if you are going to do multiple CT, CBCT, the integral dose, the skin dose and absorbed dose will increase. So it has to be judiciously used, I think. Okay. So another question is that how you handle neutron production at the installation shielding design, because in the neutrons will be produced and then the reactivation takes place.
Okay, so as far as the pencil beam scanning technique is concerned, of course, it depends upon the accelerator design. Suppose if we are using a cyclotron and if we are using a beam degrader, in that case, the maximum neutron production is going to be in the cyclotron valve. And the hydrogen content in the concrete itself is sufficient enough to absorb all the neutrons produced in the cyclotron valve. And of course, the thickness is quite large. I think in a cyclotron valve, it may go even up to 4.6 meter for a 230 MeV proton. So, there is no extra coating need to be done, because it is presumed that, or it is even verified that the hydrogen content in the concrete itself is more than sufficient to absorb all the neutron productions over there. But the second one is in the patient itself. I think, of course, when the proton interact with the patient body, then there are also some neutrons are being produced. But this is something which we have not investigated very extensively. Only some Monte Carlo studies can give some explanation about that. But with the pencil beam scanning technique, this is considered to be very minimal.
Right. Now, another question, it has with the AI also, this with the proton therapy also. What do you think to implement AI auto contour in proton therapy, like auto contour for rad formations or something? Can auto contouring be used AI based in proton therapy also?
Yes, we are already doing that. I think, of course, but all these models, I think the accuracy of all these models depends upon the training data set and the parameters, the tweaking parameters in the algorithms. And so we have to validate it, and we have validated it for the head and neck cancer patients and for 125 patients. And these patients comprises of all kind of clinical situations, pre or post of patients with the flap, patients with the dental implant. So in all those, that's why I put it as a near real world data set, and they really do quite well. But of course, I think the manual interventions are required in few critical organs, especially for those smaller and the tubular structures. But I think for the bigger structures, they do quite well. And this we have already published in Clinical Oncology, and we are also doing some sort of applying the multimodal into the entire body. So this work is in progress, and of course, before we put into clinical practice, we do a very extensive validations. Then only I think we adopt it in our clinical practice, and our dosimetric result shows that the dose difference, the mean dose difference in all these critical organ between the AI contours and the expert contour, we call it the ground truth contour, is around 3 centigrade in the entire course of treatment for head and neck patient. Sorry, not 3 centigrade, 300 centigrade.
Right. Now, there's a question for Helios. Could you provide us with more details about the current status of your center project in Brazil? And then after this, another question I will have. So one of the participants has asked, what is the status at present of your center?
So I think we're at the final stages of negotiation. After this, we're going to start a building, nothing to do more about project, is ready to start.
So is it going to be implemented soon, or just you will start the construction, bunk, all those things, and it generally takes 2 to 3 years? So what stage it is?
Not start a building yet.
So another 2 or 3 years, because you are just finalizing the deal with the
Yes, because the project maybe 1.5 or 2 years making it. So a lot of details to conclusion before to start.
Okay.
And we have some negotiations to do. I think in September we'll have an answer about all the questions.
So I think another 2, 3 years minimum to make it functional or something like that. There's another question from my good friend Axel. Again, he was, the physics advantage are well understood. Good get going project in Brazil. Despite the clear advantage coming from physics, there is no grip in healthcare communities to switch from photon beams to proton beams. The proton costs are immense. Do you have a vision when and under which condition increase in the number of new proton sites would be visible? And this is very important, how to democratize this proton therapy. And a lot of talks are there always that compact cyclotrons are coming up, the cost will go down and things and all. Anyone, Dayanand, you can take the question, or Helios can talk about this thing. How you can make it from, we know advantages of the proton, but if you see the centers, you can count on just the fingers, something like that. Why it is not becoming that is, it's only the cost. Now, how the technology can break through and when it is, because we are hearing for last 8-10 years.
Yeah, I think everybody is aware of it, how to, and the main reason behind the less number of proton therapy facilities across the world is because of the cost-benefit ratio. And so number one, so we have to reduce the cost. And number two, so we have to produce more evidences of the advantages of proton over photon. So I think the entire community in the proton therapy are working in both the fronts. So I think industry is also coming out with a cost-effective solutions like because if we consider a multi-room facilities, the gantry is more expensive than the cyclotron, right? So if you can avoid gantry, And but if you can deliver the same way how you deliver using the gantry, then definitely it is an advantage. So that's also the reason why I think in the recent past, I think we have this cyclotron with a fixed beam and with the upright patient position. So this is also a step forward towards the reduction of cost. And of course, I think even with the gantry also now, instead of having a multi-room solutions, we are getting more and more compact proton therapy facilities nowadays. I think they are so compact that I think some of the vendors are ready to install the proton therapy facilities in a linac bunker. So these are all the steps which has been taken place in collaboration with the industries in order to reduce the costs and the footprint. And not only that, I think the maintenance cost is also reduced by reducing the number of personnel involved in the maintenance of the proton therapy facilities. So that way, I think there is a significant progress. And that is also the reason why if we see the number of installations in the recent past, it's an exponential increase. That is primarily because of this cost reduction. And secondly, I think there are several clinical trials which has been conducted or which is being conducted by several proton therapy facilities, and we are also all of us are also coming out with more and more evidences of advantages of proton over photon. So probably I think so so we are, of course, I think if you still consider the number of patients treated with proton, it is only 2% of the radiotherapy patients. So we need to have more number of patients to be treated to have a meaningful clinical trial. And I think everyone is working on it. And hopefully, I think in the near futures, we are going to have more proton therapy facilities than now.
Okay, Harun, I think we're almost done with the time, but I have one question to Rabih.
Just one point, I think that is many people has asked it. If we can just quickly answer, they are asking about the cost to implement a center like that, including in the case of Helio, if there is some support from Brazilian Health Ministry or it's a private project. I think that is important, these two questions, because he also talked about the number or the expectation of amount of patients to be treated. So I think that during all this final discussion, sorry, I know about the time.
So my question to Rabih is about the AI. Are you using in your clinic these tools that you showed? And what is the perspective of the patients if they want to be involved in these studies or these AI tools?
Well, Ibrahim, on the online adaptive, for example, for sure we're using auto segmentations, auto contouring. These are tools that used clinically on the online adaptive. I mentioned the rapid plan, which is provided by Varian. We did a study that we fed the system, but this is, I think, going back to Dayanand, what Dr. Sharma what stated. It depends on what you feed the system with. So we had excellent plans that were fed in the systems and were able to produce good rapid plans very quickly. For example, we did it for head and necks and also for the breast, and they're very robust. Here, it's very essential, the validations of the tools, and this is what we are focusing our work now. The tools are there, Ibrahim. It's just now, it's our role as a physicist to validate these tools. We cannot keep this as a black box, and this is what we're working on, multi projects, honestly, part of them ourselves here in Qatar, to do some of the validations for the tools that we use with AI. Yes.
But some of the participants have expressed and they have asked also, if AI is going to do all this thing, what physicist will do and will lose the job or something? That concern also just expressed.
Dr. Arun, do you remember when we started intensity modulated inversive planning? Everybody was saying, oh my God, what are we going to be doing? I mean, I think that Dr. Sharma, everybody will share with me. At that time when we started, this is our era now, we're not young. At that time we said, oh, inversive planning, khalas, it's done. Voila, the treatment planning is going to give us the plan and the physicists are done. How much more work came to the physicists after that? From all the, we're now inversive planning is more time consuming than forward planning, to be honest with you. So I think this is no, definitely AI will not replace physicists. It's going to assist us. It's going to standardize some of the tasks for us. It will be an assistant for us, but definitely will not replace workforce. This is what I believe.
Yeah. Or should the time of 8 minutes, I don't know Magna will allow or not. Just I'd like to finish this thing. Simone, do you want to add anything? Or let me just thank everyone.
If Helio could answer these questions, he already know that the people ask in the chat. I think that's important about the cost, about the financial support, if it's private or it's from the Ministry of Health. I think that's important for them to know.
Okay, Simone.
Thank you very much. More than
cost.
13,000 participants have participated into 1,300 participants have participated into this thing webinar. So I thank all my colleague Ibrahim, Simone for organizing this, all the three speakers for excellently giving their talk well within the time. Thanks to IOMP.
Arun, he's ready to answer. Helio is waiting to answer.
It costs us around 32, 35 million euros about the equipment, and to build is around 25, 30 million euros in our country. So it depends, but in Brazil, this is our estimative. And we priority to treat a pediatric cancer. So in our country, we see the children need to proton therapy for treatment. So the financial, both public and private, it's a partnership. Okay.
Okay, thank you. Sorry, Arun.
You're welcome.
Thank you once again to everyone.
Thank you very much.
Very important talks, but we could finish in just 10 minutes or. Thank you very much for all your.
Thank you, IOMP, for the opportunity.
Thank you.
Thank you. Thank you.
Bye.
Thank you so much. Bye-bye.